morning. My name is Dr. Faisal DCS student in Shripal Hospital under guidance of Dr. Sir. I am presenting the subtopic of treatment in tuberculosis. So we have an algorithm in treatment for pediatric population, that is, we go for the sputum induced, which can be either positive or negative. If it is positive, then we go for the treatment of tuberculosis. If it is negative, then we give a treatment of antibiotics for 7 to 10 days, and we go for the X-ray after 4 weeks, and then further diagnostics for differential diagnosis or further TB management. The basic goal of TB treatment is eliminating the bacilli, that is with cidal drugs. Cidal drugs, which are HRZES, popularly known as in the acronym. H stands for isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. The drugs in TB are broadly divided into 4 categories. The first category is the first-line oral antitubercular drugs, HRZES. The second one is intramuscular drugs, which is amikacin, kanamycin, and streptomycin. The third is the fluoroquinolones, ofloxacin, moxifloxacin, and levofloxacin. The fourth are second-line oral antitubercular drugs, which is cycloserine, ethionamide. So the patients, they are further divided into broadly 3 categories. The first category is newly sputum positive patients. They are treated for 2 months of intensive phase and 4 months of continuation phase. The second category is the one which are relapsed, or they have received improper treatment, or they have received improper treatment or inadequate treatment. They in this category, the intensive phase is for again 2 months, and the continuation phase is for 5 months. The third category is the patient who are sputum negative, but they have minor tubercular symptoms. That is, for example, one single lymph node, or minor pleural effusion, or minor fever. So these are the 3 broad categories in which the patients are divided. Some specific features of the first-line antitubercular drugs. The first one is isoniazid. All these drugs, they have dose-dependent hepatotoxicity, of which the most hepatotoxic is pyrazinamide. Specific feature of isoniazid is that it causes pyridoxine, that is pyridoxine P6 deficiency. So it will lead to peripheral neuropathy. So in these patients, we are to give pyridoxine prophylactic doses also. And isoniazid, it causes hepatotoxicity and other CNS side effects. Rifampicin, again it has hepatotoxic, which is dose dependent. It gives the flu symptoms, that is fever with chills. It can give cutaneous symptoms, that is flushing and itching, and also GI symptoms, nausea, vomiting. And rifampicin, it is to be given empty stomach, and it is a very potent enzyme inducer, so it should not be clubbed with other drugs such as warfarin or OCTs. Rifampicin, another congener of rifampicin is rifabutin. Rifabutin, it has a longer duration of action. It has got less side effects, rifabutin, and it can also be used in meningococcal meningitis or brucellosis. Then pyrazinamide, which is the most hepatotoxic drug of all, it is also known for causing hyperuremic syndrome. And then we have ethambutol. Ethambutol, it was initially contraindicated in the pediatric population because it causes color blindness of specifically red-green color. It was initially contraindicated, but now it is given with caution. It causes more of, if it is stopped early, then it is reversible, and later it is irreversible. Streptomycin, it is an intramuscular drug which is known for ototoxicity and nephrotoxicity. The second line drugs, which are the intramuscular ones, and that is streptomycin, kanamycin. The third line drugs are ofloxacins. The fourth line drugs are the second line oral anti-tubercular drugs, which include cycloserine, ethanomide, and budesonide. Then there are the three categories of treatment, that is the category 1 new sputum, category 2 which are defaulted, irregular or incomplete treatment, and the category 3 which are the less severe. Now we have the multiple drug resistant TB. It is defined as the resistance to isoniazid and rifampicin. If the if the mycobacterium is resistant to isoniazid and rifampicin, then it is defined as multiple drug resistant TB. In such patients, we increase the duration of the treatment. That is, the intensive phase from 2 months, it is increased to 9 months, and the continuation phase from 4 months, it is increased to 18 months. In the intensive phase, instead of the isoniazid and rifampicin, we include kanamycin, ofloxacin, ethionamide, and cycloserine, and this treatment is given for 9 months. And in the continuation phase, we include ofloxacin, ethionamide, cycloserine, and ethambutol, and these are given for 18 months. Thank you.